Hello, everyone. WSHA and the Bree Collaborative welcomes you to the Learning Lab event on Nurturing Bonds, Solution to Integrating Newborn Administrative Day Rates for Parent-Child Well-Being. My name is Emily Noodleman, and I am the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. In my role, I primarily support the Bree Collaborative program in the implementation of the reports into practice settings and also to support the Foundation's health equity work. We are all very excited to have each of you join us today, along with our speakers, as we engage together in this event and explore how we can support a new parent-child dyad who may be experiencing withdrawal from an opioid through the implementation of Eat-Sleep-Console. As we begin, we'd like to review a couple housekeeping items. Firstly, if you could ensure your first name, last name, and credentials appear in your username on Zoom, that would be greatly appreciated. We utilize this information for our attendance records for the CE certification at the end of this event. Later in the event, you will have the opportunity to ask our speakers questions during our Q&A section. Please place any questions you have in the chat box below, and we will be monitoring that. Please ensure you are also on mute to minimize disruptions as our speakers present. And lastly, this event is being recorded and will be accessible on our website after the event. A PDF copy of the slides will also be provided via email to those who signed up to attend today. The agenda for today's event is to provide a short introduction to the Bree Collaborative and our reports, and then we'll have the opportunity to hear from our speakers. Jennifer Sandel will provide an overview on the topic, and staff from MultiCare will highlight their implementation of the extended compassion stay for Eat-Sleep-Console Newborn Care Guidelines, prioritizing support for the parent-child dyad and health equity. They will also discuss how MultiCare's clinicians ensure their charting meets the necessary requirements for accurate billing of the newborn administrative day rate. After the presentation is when we'll have that Q&A and discussion, and then we'll transition to a dedicated time to engage with peers on the call today. And then we'll wrap up. So no one in control of content has indicated a relevant financial relationship with an ACCME-defined ineligible company, also known as commercial interests. All clinical content presented will be evidence-based and unbiased. For some information on the CE approval for this event, the Learning Lab event has been approved by WSHA for individuals to attain CME credits. The CME credits are available to claim for individuals who are attending the live event only on Zoom right now. Unfortunately, we're unable to provide CME credits for individuals who watch the recording. To receive the CME credits, please complete the post-webinar survey, which will be linked at the end of this event, and I'll explain a little more details of this once we wrap up. So some of the learning objectives for the Learning Lab today are we're going to identify how a Bree guideline can be implemented into practice, recognize how social drivers of health can impact a person's overall health status, how you can plan or modify strategies to center health equity into your quality improvement initiatives, and engaging with peers throughout the healthcare ecosystem. Specifically for today's event, we'll discuss the potential improvements for SUD care amongst pregnant individuals in Washington State, explore steps for developing processes to utilize Washington State reimbursement for newborn administrative stay across the hospital system, including policy guideline development, stakeholder assessment strategies, and communication for implementation. Define local multi-care practice standards to incorporate Eat-Sleep-Console Newborn Care while promoting parent involvement. Explain the development of the billing structure to match the healthcare authority standards with the purpose of utilizing diagnostic codes and levels of care related to SUD and pregnancy and newborn care at the time of birth. So now that we want to provide some content, we wanted to review it and provide an introduction to the Bree Collaborative. As a brief introduction, the Bree Collaborative was developed in 2011 by the Washington State legislation so that public and private healthcare stakeholders would have the opportunity to identify specific ways to improve healthcare quality, outcomes, and affordability in Washington State. These stakeholders are appointed by the governor as collaborative members and represent different sectors of our healthcare ecosystem, such as hospitals, clinicians, health plans, purchasers, among others. Each year, our members identify a healthcare service with high variation in the way that care is delivered, frequently used but does not lead to better care or patient health, or that have patient safety or inequity issues. Once a topic is identified and chosen as a focus for the next year, the Bree forms a work group of subject matter experts to develop the report that provides information and guidelines for actions different audiences can take within our healthcare ecosystem to improve care for that topic. For instance, in 2023, the Bree Collaborative developed a report and guidelines on perinatal behavioral health. Our reports provide more knowledge on what can be done to support patients on certain health topics, like perinatal behavioral health, but we recognize it can still be hard to know how to implement a guideline, which the Bree defines as an action to be taken to improve healthcare for a specific healthcare service. An example of what a guideline might look like is to align with the requirements to become a birthing center of excellence from the WSHA. Criteria includes screening every person giving birth for substance use disorder with a validated screening tool. Upon admission, screen every person giving birth for perinatal mood and anxiety disorders, and allowing birth parents and infants to room together, unless the parent is in the ICU or other medical reasons, and supporting that dyad. So in today's webinar, we'll hear more about how you can implement that Eat-Sleep-Console and ensure the parent and the dyad can stay together. Our speakers for our event are Jenica Sandel from WSHA, Zibi Merritt, Anissa McCrum, and Ruth Gatika from MultiCare. I'll now pass it off to Jenica Sandel to provide an overview.
Thanks, Emily. My name is Jenica Sandel. I'm a nurse and a labor and delivery nurse by background. I'm now the director for the Safe Deliveries Roadmap at the Washington State Hospital Association. And we're happy to be here collaborating with Bree to be able to bring this to you today. So I just want to get an idea from you guys. If you take a second to find your react button and just pick a button, maybe thumbs up or a heart emoji, let me know if you are a parent. If you're a parent, you know someone who's a parent, you have a sister, your mom, dad, pretty much everyone knows someone who is a parent, right? And has been through that. And I think we would all agree that knowing that those people would do anything for their child, anything. And parenting is a unique experience. Everyone wants to be the best parent they can be, and that's not unique. So many times we hear about bias and stigmatizing language about people who have substance use disorder and are parenting. They have different sets of expectations, and we pass different judgments on them. But at the end of the day, every parent wants to do the best for their child. We hear things like they choose drugs over their babies. A good parent would want to get clean. An addict would never be a good parent. Or we know if we discharge them to the mother, quite often they're not going to be taken care of. And these are things that are harmful. They're harmful to the person who wants to do best for their baby. And we know that substance use changes the brain in a way that makes that drug use compulsive. It's a medical issue at that point, and recovery is possible. We know that it's possible, and especially with the help and the treatment and support that we can give, and that those parents desire to be, it can be very powerful what we can do to set those parents up for success, even starting with that instant of birth and how we take care of them in the hospital. So by prioritizing that parent-child well-being, we're creating systems of care that not only allow, but encourage those parents to receive their medications for opiate use disorder and remain with their newborn, to bond, to learn how to become a parent, how to give them a bath and change their diapers and all the things that you just have to learn right off the bat, and how to care for their newborn. So this is the best care that we can give to these vulnerable populations of people, and hospitals dedicated to providing that kind of care now have some support to be able to do that. So next slide, Emily. So how do we provide that kind of care? It comes down to a coordinated effort to maintain that dyad, the parent, the birth parent, and that baby. And we were lucky to be in a state where agencies across the state collaborate to do just that. DCYF is working in reduction in removals. There's a primary recommendation for reimbursement for non-pharmacological first-line treatment for those babies that are maybe born affected by substance use or exposed in utero. You mentioned Eat, Sleep, Console, kind of using that term that we sometimes hear, mother is the best medicine. How do we keep them skin to skin and provide all of that comforting care that newborn babies so crave in their first time in life? The Department of Health, the Healthcare Authority, the Washington State Hospital Association, there and more. Everyone is working together to find ways to bring together policy, housing, treatment, prevention, all of the things that need to come together to be able to support this population of people. Next slide. So there are priority efforts to improve services for those populations. So we know that the Healthcare Authority is a purchaser of about a third of residents in Washington, and that they're dedicated to making sure that those high value services are available and good quality care. So focusing intentionally on these dyads that are exposed to substances, BIPOC, the people who we need to lift up and support in a way that will make sure that we can provide better care and better outcomes for everyone across the state. We know those are not everyone experiences the healthcare system equally. And sometimes we need to give more support and resources to people who need that in a way to be able to access the same amount of care that someone else might be getting on a regular basis. So between 8 and 11 newborns, and 8 and 11 per thousand in the state are affected by substance exposure. So we know that there's a good number of people who will need this kind of care, and it is important for us to be able to provide that kind of care and best practice. Next slide. So it really takes everyone working from all angles to be able to provide that kind of care and best practice in a complex system like healthcare. Policy efforts, system improvements, care delivery systems, the direct patient level care. That parent-child well-being means that we need to ensure that those systems are in place to be able to provide the personalized care that those dyads need. So in recent years, there's been a movement kind of to have this non-pharmacologic supportive care for newborns. One method is the Eat-Sleep-Console method that we'll talk about later. And this means that we're prioritizing the mother and their support as their mother as medicine and to do what they need with the baby. But for many people, they have to travel quite a distance, depending on what community they live in, to receive their medications for opiate use disorder. And that takes them away from the bedside, sometimes for hours, to be able to make that trip. So this was recognized as a barrier in providing optimal personalized care, but there wasn't a mechanism for the hospitals to be able to have that person stay with their baby. And being able to stay inpatient and receive their medication when they would have normally been discharged has been is a way for hospitals to be able to support that prioritization of the parent-child dyad. So that's where the administrative day rate comes in. If you go to the next slide, we know that the administrative day rate's been in use for other types of patients for some amount of time. I don't even know how long, but for quite a while. But those payments are usually for hospital stays where they don't meet the criteria for acute inpatient care, but they're used when they can't quite get to their appropriate outpatient placement. So it might look like someone who's going to be ventilator dependent. They're awaiting their outside placement, but they still need that skilled level of care. You can't just discharge someone that isn't able to take care of their own ventilator services. So there's this day rate is available for hospitals to be able to provide the level of care that the patient needs on an inpatient basis, even though they don't meet that criteria for acute inpatient care anymore. So this is also now thank you, Healthcare Authority, for being able to work through this through policy, is to be able to provide this to newborns. And it is actually provided to the parent who is staying with the newborn that was substance exposed, and they're working on that non-pharmacologic treatment that usually takes about 5 days to monitor and keep an eye on. So it allows the parent to stay at the bedside, receive their MOUD, other supportive services like lactation care and discharge planning. But we know that it takes a lot of work to put a system like that into place, and there's a lot of little details that come up along the way when you try to put something like that in when it hasn't previously been used in that population. So if you go to the next slide, we're going to hear from a hospital that committed to working through all of those little details and those steps necessary to be able to create a care delivery system that truly does prioritize that parent-child well-being for this vulnerable population. And thanks to their trailblazing, we learned a lot along the way. And luckily, they were good about giving us feedback on how things were going. So we were able to create some information and guidance along the way that might help other hospitals, like an FAQ about the newborn administrative day rate and some example guidelines that a hospital might be able to use to help support their implementation efforts. So we have a few things linked here. They'll be available afterwards, but these are local resources that would be helpful if you're interested in bringing this to a hospital near you. Each hospital may choose internally to name their process something meaningful to them. And I'm excited to introduce the MultiCare team to talk about their compassion stay and how they're able to prioritize care for the parent-child dyad.
Thank you, Jenica. I'm not sure. Oh, geez, I just lost. Okay. Is Ruth able to come on camera? Do you see her, Anissa? Or introductions?
I do not see her yet.
I do.
Okay. Perfect.
Thank you.
Great. Well, thank you so much for having us here today. My name is Zibby Merritt, and I am the nurse specialist with MultiCare Health System. I'll be speaking to you today as well as Anissa. I'll let you introduce yourself.
Hi, everybody. I'm Anissa McCrum, mother-baby manager at Deaconess Hospital in Spokane.
We have
Ruth, you're on mute.
My apology. I'm Ruth Katika, and I am from Revenue Integrity, and I am a CDM Analyst Senior.
Thank you for joining us today. So those ladies will turn off their camera, and we're going to flip between who is presenting with you. So next slide, please, Emily. We've already covered our objectives, which is a great thing in detail. So I'm going to start here with what it took, I guess, in order to get this working for our system. When it comes to success, we know that culture is where it starts. The culture around substance use disorders needs to be one of acceptance and affirmation. We know, as Jenica said earlier, that addiction is a stigmatizing disease. It is a disease of the brain, nevertheless, not altogether different than diseases like diabetes or coronary artery disease. It is not something that anyone chooses purposefully. And so the treatments for substance use disorders involve holistic care of the birthing person and their entire family. So we have an opportune moment to harness the intrinsic motivation that comes with pregnancy and the birth itself. The care that we provide needs to address both physical needs as well as emotional needs and social considerations, while at the same time realistically balancing people's real-world concerns and being patient-centric with our goals and expectations that people carry with them. To put together this plan that made sense, it took a lot of stakeholder involvement. So we had a couple of really active physician and midwife champions that understood what it meant to take care of a patient from the moment they found out they were pregnant to the trials and tribulation of postpartum. We needed people who were passionate about this work, and so we signed them up to help. We needed nurse leaders who were actively engaged and thought creatively to solve problems, because we came up with quite a lot of steps along the way that we needed to address. Social work was truly the glue that held this together, because our incredible social work partners met with the patients. They understand the big picture and what long-term success looks like for families. We had to listen to the needs of our bedside nurses in labor and delivery, and mom baby, and our nursery staff, because they're the ones doing the real work with the patients, and they are the ones that told us what we needed to hear and know and do to change, to adapt to what this had to look like for our patients to feel successful. And then Ruth is going to sort of translate for us, if you will, a whole nother language of billing and financial services, because although as a nurse, I know what it looks like to provide good care, it's really complicated when it comes to those details related to reporting to the state and getting reimbursements. I learned a lot along the way with this process. And other stakeholders were, you know, anyone else who really comes in contact with these families, whether that's the people delivering their meals, people that are getting labs, our security partners, everyone who needs to reach out to these families in a new, unconventional way. This isn't the typical nurse-patient situation. So we wanted to make sure that everyone was aware of the program that we were doing and could understand and be accepting of it as well. In addition, our community partners, we had to set up services for patients after they left the hospital with their compassion care. We reached out to the Vanessa Behan Crisis Nursery here in Spokane to see what we could do to find placement help for older siblings when a new baby is born, if family wasn't immediately available to help new parents. And most importantly, at the crux of this is our patients. What was it that they needed in order to be successful with Eat-Sleep-Console? Back in 2018, the social worker at Deaconess, Bree Collaborative, and myself and the managers at Deaconess put together what we called the Journey Through Recovery program. It was kind of informal. It was a monthly meeting where we encouraged patients to come to the hospital to see where they would be staying, to talk to the nurses who would be caring for them and their baby, and to really invest in what this would look like for them to be successful. Visualize, if you will, what they needed to know to be successful when birth came around. We don't actively have this monthly program anymore, but the invitation still stands. Anybody who wants to know and see and feel what it'll be like once they deliver is welcome to come and be prepared with our staff. Part of that work was also pretty extensive implicit bias training. We know that personal recognition of what we bring to the care we deliver can make a real difference to our patients. So we kind of had that mindset of check it at the door. Even though we know we all come with things, what can we do to put that aside as soon as we enter that room to become better connected with our patients at the time that they need us most? And hugely to credit our staff and our managers is this flex and flow mindset for both bedside staff and our leaders. We had to be really creative. We cross-trained NICU nurses for couplet care. Any of you that are NICU nurses understand not usually big fans of taking care of moms. We had to come up with new staffing ratios. We had to come up with new ways to communicate. We had to partner with our lactation staff in a different way. The ability to be flexible and just sort of go with the flow for what that family needed was essential to our success. And of course, at the end of the day, it was all about the patients. Next slide, please. So I don't know if you abide by the same saying that I like to use, but clear is kind, right? And so what we decided to do as an organization was kind of develop a playbook so that we knew what everyone was accountable to and for. What is my responsibility when it comes to taking care of these families? When we define what the work should look like, it makes things run more smoothly. So what we did is we kind of looked at it from the team lens. We had everyone from the HUC that was inputting the information in the charts and welcoming the patients when they arrive. We had to speak with our delivering providers, telling them that it's going to look a little different because when this patient is medically discharged, they're not actually going to be leaving the hospital. They'll be staying to care for their baby. We worked with our nurses, again, our social work partners, even security, because sometimes there were situations in which we had to be a little more lenient and also a little more strict based off of the situations that our families presented with. And we also had to work with our pharmacy partners and providers to provide medication-assisted treatment for our patients for their MOUD purposes. So when we looked at what our patients needed to know, we found from our early journey through recovery program that the more prepared and the more informed they felt, the better they seemed to do in reality. So we talked to patients. What are the barriers to you feeling successful? What does it feel like to get good support from our staff? We know it is not easy to stay in the hospital, and we're asking these families to stay up to 5 additional days. No matter how motivated you are, it is not home. So what can we do to make this feel like it's a doable situation for you and your newborn? Anyone who has participated in Eat-Sleep-Console knows that it is not easy to do any of those things. Oftentimes, it takes a lot of commitment and support to get this baby breastfeeding. It also takes a lot for a substance-exposed baby to be consoled sometimes. It might feel nearly impossible sometimes with our polysubstance-exposed kids. So having the ability to partner with lactation, occupational therapy, experienced nurses to complete this like teaching and support for our parents has been essential. When we set up people for success, our definitions changed a little bit along the way, to be honest. We had to, as I said, be really creative in staffing between the units. People had to be willing to bounce from one assignment to another because sometimes a baby would go from sleeping a really nice time to being really difficult to console for an hour or so at a time. We needed time for social work to come in and do their work to actually help our families and set them up for long-term success, especially with MOUD therapy. And we knew that we needed to create medication and inpatient standards that worked with hospital bylaws, because as you know, there are certain things when patients stay in the hospital that just have to happen. A physician has to round on them every day. They have to have some sort of orders that carry over so the nurses know how to care for the patients. And we had to partner with pharmacy to make sure that our patients could get the medications they needed to be successful. So originally we thought about an order set, but we ended up going in a different direction. And Anissa will help explain how we simplified things. So on the next slide, you'll see just sort of the basics that we sketched up. And this is what we came up with as a system guideline. We have other system documents that speak directly to Eat-Sleep-Console practices, but this was intended to help define the process and the roles for those who were involved with the extended newborn administrative stay. On the right side, you'll see a patient agreement. It's not binding, it's not a behavioral contract. It's just meant to sort of clarify the expectations and speak to some of the most difficult pieces to this type of stay. Visitors, leaving, or rather the inability to leave the facility, how it looks to care for the baby throughout both the day and night, and what the staff will be responsible to provide to the family, clarifying those expectations so that we can be successful. So to explain a little bit more how this works at Deaconess, our mother baby manager, Anissa McCrum, will take it from here. Thank you.
Thank you, Zibby. Next slide, please. So I just want to give a little background about Deaconess Hospital and our Eat-Sleep-Console practice. So we started Eat-Sleep-Console back in 2019, June 2019. And recently, just about a year ago, due to the fentanyl crisis, as you all know, the past couple of years, we were seeing a lot of babies that were withdrawing very hard from the fentanyl, and we had to readjust our algorithm on our guidelines for Eat-Sleep-Console. So I will show you that in a moment on the second page. Our goal, of course, is to keep the couplet together if safe to do so. And we, on our mother baby postpartum unit, we have 5 rooms that we kind of designate as Eat-Sleep-Console rooms. And we try to do our best to put our Eat-Sleep-Console babies in that same area. So that way, and mainly for staffing, as well as it's more quiet in the back hallway. But also for the nurse that's taking care of maybe a couple of the couplets, she can be close by because they do need a lot of, extra assistance sometimes. So we staff per A1 guidelines. That's 1 RN to 3 patients. And then at 24 hours, when typically when the mom, if it was a vaginal delivery, the mom will be discharged to the room at that time. And either the NICU or the mom baby charge will make sure that there's a NICU level of care. 2 per protocol cosign required order put in Epic. And then that allows for us to get, a higher level of acuity reimbursement for that NICU, higher level baby that's on postpartum. And then at discharge also of the birthing parents, so at 24 or 48 hours when we're discharging mom to the room, we consider transfer to compassion stay. So typically all of our Eat-Sleep-Consoles, we've already had social work assess and make sure that it's a safe, environment and a very qualified couplet to do Eat-Sleep-Console. Mom is usually, she will be either already on methadone and Subutex, or she came in ready to get treatment at delivery. And we have, as long as there's a lot of support and it's a safe place for the baby, we will also allow those moms to do Eat-Sleep-Console depending on the situation. So staffing again remains 1 RN to 1 to 3 or 3 to 4 patients, depending on the infant symptoms and escalation needs. Next slide, please. So this is the example of our educator here at Deaconess did an excellent job listening and supporting as I was bringing up concerns about just some situations where the nurses and the baby were put in unsafe situations, and so we needed a clear tool to help our labor and delivery nurses when we don't have social work available. A lot of times these patients will come in on the weekend, no prenatal care, active use at delivery. So we needed kind of an algorithm to help those L&D nurses decide if this was appropriate for Eat-Sleep-Console or not. So I want to just bring attention basically to the top here where we added in, so the patient's first admitted to labor and delivery, and then the L&D or the L&D RN or the charge RN will assess substance use concerns and perform a chart review regarding any illicit drug use from patient or support person. And then they'll consult with the provider for urine drug screen if needed. They assess for safety of the environment for the newborn, and social work, of course, will consult as soon as appropriate. And sometimes that's hours later after delivery. And we have social work typically in our building, assigned to our building Monday through Friday. So she is not here on the weekends typically, but we do have other social workers that can fill in. And then we have, we just try to make it as clear as possible. Like if we do have an unsafe situation, so for instance, smoking fentanyl in the hospital, in the patient room, that's exposing the newborn, it's exposing staff. And we have had that happen.
I'm back in the meeting again.
Next slide, please. So how did our unit make the compassion stay work? Again, like Zibby was talking about it, our culture at Deaconess has been respectful maternity care as we continue to work on, removing bias and just a culture of sharing information and building relationships. So really required was a relationship with our charge master analyst, Ruth Gattaca, as well as our social worker, our providers who were really invested in helping these substance use disorder patients, our bedside RNs, the managers, our educators, and the peer counselors. Open communication was necessary. So at discharge, when the parents were very appropriate and always involved in the baby's cares. We wanted to help them stay and, stay with their baby and stay for the entire time and not have to leave the hospital and go get their medication. And so we wanted to make things as easy as possible. So I would track the MRNs of these patients. There wasn't a large number of them, so it was fairly easy for me. Most of the time, my door is open here at Deaconess, and I'm close to the nurse's station, so I will hear what's going on. I'll go check in with the team, and they know to ask me if, they're wondering if someone's appropriate for a compassion stay. The social worker will come in and ask me, and we talk about it and decide, yes, this is the right thing to do. So I track those MRNs, and then I would send them in a group email to our charge master, Zibby, as well as one of our providers who's very invested in this work. And we just tracked those and made sure that we were going to get the reimbursement back. So it was a lot of communication. And this, of course, this works for all of our Eat-Sleep-Console families, as long as they are, involved in their infant's care and being safe for the baby. We have had all those moms stay for the compassion stay. We have also attempted to do NICU moms just because it felt like the right thing to do. That is still something that we're investigating whether we get reimbursed for, which I still need to follow up with Ruth on that. But sometimes we felt like it was the right thing to do, that like a NICU mom who's very involved in her baby cares goes up for every feed up to the NICU. We wanted to support her and be able to help her stay in the hospital close to her baby. So we have done that before, as well as we had a recent situation where we had a COVID positive NICU mom. So we really had to get creative and brought a video, a monitor in there so she could be involved in baby cares, but she wasn't able to go to the NICU to see her baby. So just always thinking outside the box and communicating with the team to figure out if it will work. And here at Deaconess, we just continue to try to do the right thing. So that's what we've been doing. Next slide, please. Here is that example of our compassion stay order. So a lot of times I will have to, so I sent this out in an email initially to all of our provider groups, our OB providers, because this is how they have to put the order in for us to get the reimbursement. So this is the example of what we came up with. It does need to be a level of care change, the WNS SUD compassion stay. And then we decided just to make it simple, like Zibby said, we didn't go with a whole new order set because basically not much is changing. So they just added a quick MD to RN communication order that reinforces that we're going to transition that patient to compassion stay, continue the diet and medications and vital signs once a shift, and lactation and social work as needed. So whenever we have this come up where we do have a compassion stay, a lot of times I will be involved and I'll remind the nurse, I'll print it out. I'll print out this example order. I'll make sure the provider remembers how to put it in. And yeah, that's how we got it done so far. Thank you. Next is Ruth Gatika. I will make sure I pronounce her name right. Thanks, Ruth.
Hi, thank you, Anissa. So I'm going to be speaking about the billing structure and how we actually were able to capture any compassion stay admin rates and the process of how we made it possible for it to work. So what we did, on the electronic medical record, that level of care that Anissa mentioned was created in the system to identify the compassion stay encounter. So when the patient is medically discharged, a transfer order is entered versus the patient being discharged and readmitted. And the transfer order is truly what works best because it continues a continuity of care for both the mom and being transferred over to the NICU with the patient. That level of care that was selected, as Anissa mentioned, is the Women's Newborn Services for SUD Compassion Stay. And again, here's another picture of what it looks like. And when that order is submitted, it actually will trigger, which we had built in the background in the system, which was a rule and a property and an operator and a value background in order for it to trigger that encounter. And once that encounter is triggered, can we go to the next slide, please? it will trigger the services. And so what it allows both for the services, both for the clinical side and also the billing side, the postpartum patient will be transferred over for that compassion stay location to care for the newborn while the newborn is still in house. The parent remains and is transferred over with the newborn for a 5-day compassion stay for the ESC, so we can be reimbursed through state funding for those 5 days that are additional reimbursement for us to receive. When the newborn becomes a patient of the NICU, whether that be virtually or physically, the birthing parent is transferred over to the compassion stay. And as both Zibby and Anissa had mentioned, it promotes 24/7 bonding. The parent is still in house, so they will continue to receive meals and they'll continue to receive their medication, especially their MOU medication for the SUD treatment. And then each day the hospital will get a room and board reimbursement for those days that the patient is in there until discharge. When the patient order is transferred, not discharged, to the WNS Compassion Stay location, the level of care, it creates what we call a billing indicator on the back end of the electronic medical record encounter. The billing indicator will allow for it to default to a work queue which we built for this specific program, and it will allow those encounters or those services to default into this work queue, again, by updating our electronic medical record with the property, the operation, and the value on the system. It also will identify payers that are part of this program where we will receive that additional reimbursement. And so I just kind of put a little snippet of what our billing indicator looks like. Next page. So as stated, everything for the EMR, we built a work queue and also a back-end workflow. Once those encounters default into this work queue, the documentation and the encounter is reviewed to ensure that nothing is missed for us to be able to, add the charges that need to be added. The administrative rates are updated and entered manually. And then on the back end, the claims are split for the medical services and also for the SUD claims. And we actually adhere and follow the DOH admin day rates, room and board billing, along with the ICD-9 diagnosis guidelines. Next page. So when we bill for these services, for them on the mother's encounter, not the newborn, we use the revenue code of 0191. We actually add the correct diagnosis, which is the ICD-10 diagnosis code of 099320 for drug use complicating pregnancy on the postpartum provider 1 ID. We bill the medications for postpartum patients on a claim separate from that of the acute care stay. HCA does not require any prior authorization for these fee-for-service clients. So whenever the level of care is selected and it is processed, there's no prior authorization needed. The provider, we must bill with the inpatient status code of 30 to indicate that the provider will be submitting a separate claim for the newborn administrative rates. And we also include a note for the admit days for the claim to follow. And then once it's submitted, we have had great success in seeing some reimbursement for those services as long as everything is aligned and the electronic medical bill that's in the system actually is working as it should, and it's going great. And thank you. Next slide. And that's it. Thank you, everybody.
Thanks for, I'll now invite Zibby and Anissa back on with you, Ruth, and we'll open it up for Q&A with our speakers. So if you have any questions, go ahead and post them in the chat and I can work on asking them to our lovely speakers. But as we wait for some questions to come in, I just had one, which is, what were some of the key challenges MultiCare faced during the implementation of the extended compassion stay, and how did you overcome them?
Well, you've heard of the expression of building the plane in the air, Emily. I think that was kind of it for us. We asked, you know, what are other people doing? How is this working well? And is anybody doing this already? And it didn't seem as though there were a lot of real life resources available. So as you heard from Ruth, it's a whole other language. There's no way that I would have been able to understand what she just explained without her knowing all of that. So the challenges, I think, were met as soon as we got together as a team and said, okay, I know this little piece of it and you know this little piece of it. So what can we do to get it together? But I think the challenge for us was kind of, I mean, as far as I know, being one of the first ones to figure out how to process these claims. And we're more than willing to share it with other people so that people don't have to go through those same, you know, what about kind of scenarios. So I don't know if Anissa has anything else to add, or Ruth.
Yeah, I was thinking our providers needed, you know, to understand where the coding part of it as well. So I connected them with Ruth, you know, and she was able to answer their questions when it came to what they needed to chart, you know, and things like that. Like Zibby said, it's a different language for me, so I'm not at all educated in the coding part, you know, bare minimum for a nurse manager, but Ruth was able to answer those questions. The providers were understanding. And so just like, again, building those relationships and connecting the right people to the right people so that we could figure out, you know, the correct charting so we would get the reimbursement.
And I'd just like to add that a lot of it was also fine tuning our process because we did have a lot of fails and then we had to work through those fails to make it successful. So we fine tuned quite a few times in order to make it work, both when it worked, working with Zibby and Anissa, and also with just our team to make this possible. So there was a lot of fails, but then we ended up with some success as well.
Thank you. In your presentation, you emphasized culture is where it starts. Can you elaborate on how you've worked to create and maintain this culture, particularly in the face of staff or leadership turnover?
I can speak to that. I've worked here at Deaconess 16 years now. I just had my work anniversary, so quite a while on Mother Baby. And we have had different ownership, several leaders. I think consistent leadership and leadership stability has really helped our building. We have had a manager in L&D, a manager in Mom Baby, and a manager in NICU for the past 4 years, going on 5 years. And it's been very helpful for decreasing our staff turnover, you know, making sure that things are communicated well and with people that have worked here several years. So I think we're lucky to have that with the decreased turnover recently. But prior to that, we had a lot of different leaders coming and going, and a lot of staff left, you know, and so I think that's kind of where we're in a good place right now when it comes to stability, which is good. With all the changes that are constantly coming at the nurses, and it's, you know, our burnout is still very high on my unit specifically. I have 34% positive for burnout, but yet 94% positive for work-life balance when it comes to employees giving their feedback. So we still deal with burnout, but we are all here, you know, it's a good culture. So I think we're really lucky to have the people we have.
I think to tag on to that also, Emily, if you see it work. You know, it's one of those things where it's a good kind of infectious nature because, you know, we all have patient stories that have moved our hearts and our minds in the right direction as well as in the wrong direction. And so keeping hold of those things that move you in the right direction, that's really encouraging. And all it takes is a couple of nurses to buy in and say, did you see she went home with her baby? Or even if we get them to stay for a couple of days and do more cares than they would have otherwise, we know the long-term impact of that for our families and our communities is huge. So I think it just takes a few wins, like Anissa was saying, and then all of a sudden it becomes no longer can we do this, but this is what we do. This is how we do it for our families. And I think the nurses and the providers and lactation, everyone is just really proud and grateful that we have the opportunity to even just get the small amount of reimbursement, because it shows on every page that it really is doing more for our family and our community.
Thanks. There's a question in the chat that says, is MultiCare seeing success in the reimbursement with Medicaid MCOs in addition to the fee-for-service plans?
I'll leave
Yes,
that one to Ruth.
Yeah, so what we do, we actually adhere to the HCA guidelines. So we actually had everything built in the back. So it really had to do with payers when we're receiving this reimbursement. And as you know, a lot of the compassion stay have certain payers that are allowed to provide for the services. But I do know that if it extends outside those payers, we still bill accordingly. But the reimbursement really works well as long as we follow the guidelines that are needed. And so that's one of the reasons we actually had a work queue built to ensure that the documentation was there, the level of care was actually appropriate, and then updating the room and board rate to provide that, and also, just like I said, the workflow. And as long as everything kind of follows through the recommendations, it's being really positive. So, and then we also have follow back. Let's say that for some reason it's not paid. We get together as a group, PFS and myself, to see what's missing. And then we usually capture it ahead of time, and we're able to address those. So I do work with the team. For some reason, if there's a denial or something is missed, and then we actually relook at that claim, and then we send it off the door. But usually it happens now very rarely. But we still, if we get one or two encounters, then we actually address them to see what's missing.
Thanks. I see we have a question from an audience member. So is it Alpina? Do you want to come off mute?
Yeah, I just want to introduce myself. I am in the maternal mortality review panel, and I'm by also a mental health instructor. Apart from that, I'm involved in so many other things. But my question here is, what strategies being in MultiCare, what strategies are being implemented in your organization to ensure patients feel heard and their concerns are taken seriously? Because we have done case studies, and we have being in the cases where we have seen and heard people complained us that they were not being taken seriously by the nurses. And I know sometimes whatever the nurse writes, the doctor signs on that. So in that case, what actions you guys take? What are strategies you implement in your organization? I want to know for myself.
I think that's a great question, Alpana, and that speaks to the culture and the training that our nurses get and renew each year. We have a new or a renewed focus on trauma-informed care that we're trying to look through for our nurses in our organization. We do a lot of cross-training with our emergency department nurses for SANE, the sexual assault nurse examiner training, and how we talk through difficult situations that have happened for our patients. And in addition, that's kind of why we had that patient care agreement as part of this work, is really sitting down, having an intentional conversation, whether it be with social worker, the delivering provider, the nurse, whoever it might be, to really understand what we can do to make the patients feel like they will be successful. What does support look like for you? Because for each family, that's different. It's different if you have two older kids at home. It's different if you're a single parent. It's different if you desired this pregnancy or didn't, or your baby's in the NICU unexpectedly. So I think it just comes down to that personal nature of making that connection with that individual and understanding it from a trauma-informed lens.
I was also going to mention a few things that MultiCare has done that I was thinking when you asked that question. A couple years ago, probably 3 or 4 years ago, we started HRO, the High Reliability Organization. We require all staff to go through that training, a 4-hour class. And so that's become a culture of safety at our hospital, as well as Cypher leader rounding. At first, leaders felt like that was another task, but now I find it very powerful for patient satisfaction and listening to the patient. I make it a priority to go out there as the manager and make sure that either I lead around or I delegate to, the charge nurse or someone to go in and lead around if I'm too busy. But I do frequent leader rounding where I can listen to the patient and make sure that we're doing a great job taking care of them. And if not, I try to resolve and listen to them in the moment and see what I can do to help. And then we're also working on team birth, which is through WSHA, and we're in the third cohort. So going live in a couple months, in October, we are going live with team birth, which is increasing the communication at the bedside with the patient as the center of the care and center of the communication. So doing huddles at the bedside with all key players, the provider, the social worker, the nurse. And so to get my staff to buy in for this new thing that's coming, it's hopefully going to make it easier for the nurse. So they're not bouncing back and forth between the provider, the patient, being that ping pong ball where you got to keep, calling and communicating to several different people. Instead, we want to do the, huddle at the bedside with the patient so that everyone's hearing the same thing. We're all talking about the same plan of care.
Thank you so much. And I just wanted to know that you acknowledge that this has happened. You know that it is in your, sometimes what happens is the nurse, the supervisor doesn't even know what is happening with the patient and the nurse, what did the nurse did with the patient, and the patient has to go back to home, and then she's coming back again bleeding and pain and with some other problem, deficit. The doctor diagnoses that this is something serious now because she's been pushed to go back to home. So in that case, is like, I understand that we have crossed, it's 23 years in the United States now, fighting for justice and women, mental health, everything, And now I have realized it didn't personally happen with me because I'm a different personality. I ask what injection it is, or why you are giving, but not everybody is like that. They kept quiet. And they shows their eyes that you can walk. Just get into the bathroom, do your bathroom yourself and come back. And she did. And after that, it was extreme bleeding and very worse condition. Even that has been taken care on that very day. And then she is been released, go home. And when she comes back, it was some kind of infection or something. I'm not a medical complete person that I can give you what exactly happened. But something happened that it was much more serious. The doctor diagnosed it shouldn't happen. There was a mistrust between the patient because she was a Latino girl and she could not probably express, or she didn't have the courage to say everything. She kept quiet, and this thing happened. It shouldn't happen because in case the child dies in these two, exercising this behavior, then who is going to be in loss? The women, and she will be in mental torture.
I think you're highlighting the importance of listening to our patients and making sure that we are building relationships with our patients, and also how Zibby and the group was highlighting just providing compassionate care as our theme in today. We need to continue to the next question. Looking at the time, but thank you so much for raising that point. There's just a couple questions in the chat asking more about NICU level care. One is, how long is compassion care an option for a patient in the NICU? And for the NICU, what documentation is required? Specific parent engagements. Oh, it just jumped. Specific parent engagements and timing of the engagements.
Well, like I said, now that I'm looking back at my finance report, I'm not sure that we have been reimbursed yet for the NICU specific, when the baby is not on postpartum. But we have done this twice that I can think of for NICU parents, just because they were so involved in cares. And especially with the patient that was COVID positive and couldn't go to the NICU, we made it really evident through report, between mother, baby, and NICU that the nurse needs to chart those parent interactions. So even though it was over video or phone, like, those those interactions have to be documented so that we could, you know, prove that the mom was involved in the baby's care as much as she could. Thank you. I think that's all I know right now. It's a good question.
That's okay. There was also a question about your volume of mothers that take advantage of the service that you're seeing. Could you elaborate a little bit more on that?
I know Ruth is seeing more of those actually from one of our sister hospitals on the west side through Good Sam. But I was looking at my my data where I can see my revenue for our unit, and I know, like in September of 23, we had eight days documented and reimbursed for. October last year we had 4, so it's not like a high number. But then November we had 9 days reimbursed. December 5. So to kind of give you an idea, we're anywhere from like 4 to 9 days per month.
Right. And actually, she's correct. I think a lot of it, as I mentioned, was a lot of refining our payment and how it works. And we had to go back to the drawing table as to say, to redefine our workflow when it came to having those charges or that encounter for the mom default into our work queue and making sure that it worked well. So as of 2023, I think the volume was quite low because a lot of the information that was needed and required was missing. But I think moving forward, now I'm seeing a lot more encounters that are actually defaulting into the work queue, which is really great. For, as Anissa mentioned, some of the other hospitals where they are actually documenting. Absolutely wonderful, because even though we get the level of care defaulting that encounter into a work queue, we have to make sure the documentation will support those visits. And so they are noting where we have the physician come in and they document patient being transferred to compassion care. And then their note actually states compassion care. So we can actually verify the documentation, the notes, and then when they're discharged, they actually have the discharge note also from when the compassion care is completed. And we do have another program. And so if that other program, if they're transferred into that unit, then it's also documented. So a lot of it is when it works well. And I think that we really have fine-tuned both on the departments and also with our process for billing out these services. I would say it's working better now than it has in the past, but it has taken, like I said, trial and error and just fine tuning what needs to be done. And communication, as both Zippy and Anissa mentioned, it's very important, because if a piece is missing, then I usually reach out to the leaders to really find out, did this happen? What can we do to actually get the reimbursed? Where's a note? So we do have a close relationship where we can actually reach out both for the billing side of what's needed and also with the leaders from the unit for us to communicate that, so we can actually get the reimbursement and we can split that bill accordingly. And it is 5 days is what they allow for us HCA, and they do have an extended days if it goes beyond the 5 days, but it will need an EAP code added for the additional days. And so we haven't met the extension after 5 days, but if it does happen, you have to have an EAP code for that extended day and that will take prior authorization for that component.
Thank you. As we're working to kind of conclude the Q&A portion, I had one last question: is how are you measuring success of your extended compassion stay in terms of patient outcomes and also your staff satisfaction? Like how is that going? To know that your staff are okay with this, they're happy with this implementation, but also that your patient outcomes are more positive.
I think it just goes again with our culture that we've, developed. I'll just say the people, because honestly, I haven't heard any complaints, and I know our patients definitely appreciate that the nurses really treat every patient the same. I don't see a lot of bias with my team. I know that they go in and take good care. Like I said, through my leader rounding, I ran with all these patients and I would hear if there were complaints, and we don't get them too often, luckily. So it makes my job way easier. But yeah, just the nurses haven't complained about it. They're like, how do we do it? Okay, that sounds like the right thing to do. Let's do it. So it's just a great team that we've developed and a really safe culture to bring up, concerns. We share about our patients with each other so that we all are in the know with how to best care for all the patients on the floor. Hope that answers it.
I think another thing that we have an opportunity with, Emily, is thinking upstream in terms of success, because we could be engaging more families, I think, had they had the ability to feel more prepared. And so how can we reach earlier in pregnancy? Because we know that the people, as I said earlier, that feel more successful are grounded in the ideas, they've bought in, they understand what the commitment is. Of course, we try to reach anyone and everyone that comes in and shows interest in participating in Eat, Sleep, Console, but we know that people that have had a lot more time to think about it and be prepared, get them when they're motivated, right? As soon as they find out they're pregnant and they understand what that will mean for their baby being substance exposed. I wish that our success metrics, to me, to improve it as the nurse specialist, would be that we would harness people earlier on in their pregnancy in order to get more families that could be engrossed in this work, and that would make everybody's lives easier because our nurses would have prepared patients, and our patients would feel what it means to be successful with this.
Sounds great. We'll now transition to those small group discussions. You'll see here in a moment that you're invited to participate in one of these rooms, and we will have conversations that are facilitated by some staff. So I believe they're open now, so you should be able to join. We can help you if you need any assistance in joining that, but we'll just have an opportunity to connect with peers, and then we'll come back together and share out a little bit and wrap up. And I'm going to invite Jenica to share some information that was shared during your group breakout and your small group discussion.
Yeah, so we had a great group of variable care areas across the state. So we talked about how important it is to have the team and have everyone from different silos that typically don't always connect in the same way, be able to participate in this way, and that prioritizing the dyad and that bond, it can have an exponential impact on the community and building trust and psychological safety for them to be then able to maybe access healthcare later on if they need to, because they felt like a valued human in their interaction. So how do we make sure that we're doing the right thing for them, and at the same time at a policy and impact level, make sure that we have the financial support for hospitals to be able to do the work?
Thank you. We want to just thank everybody for joining us today. As we close out, I wanted to share, so we're going to post the post survey in the chat right now. Please complete that survey in order to claim CME credits. I'll show you on the next slide how to do that. But we also wanted to share, we have some upcoming events that you may be interested in joining us for. On October 4th, our sister program, OB COPE, is hosting a webinar on the topic of induction of labor. On October 15th through 16th, our other sister program, Washington Patient Safety Coalition, is hosting the Northwest Patient Safety Conference, which is a virtual event. On October 16th and 17th, there is a Wellness and Addiction Summit that is hybrid, and it's located in the SeaTac area near the airport. And on October 18th and 19th, we'll have a specific focus on perinatal behavioral health. So you're welcome to join us there. That is a free event. And then on November 7th, we are hosting a Social Need and Health Equity Summit, which is also virtual, and you can attend at no cost. All of those links are placed in the chat. I know Jenica has some events too, and we'll make sure we send this out with the recording and slides. So Jenica, did you want to share your events?
We can put a link to them in the slides that we send out. We have scheduled events every second and fourth Thursdays, and then we also have our in-person event will come next on November 7th in SeaTac.
Perfect. Just so how to claim that CE credit, you will see, we'll ask you to complete the survey. Once you hit submit, your screen will look like this, that blue box that you're seeing. There's an option if you want to claim continuing medical education, so you'll click that here button. If you want to claim CECH for nurses, please click the here button on that line, and that will take you to a claim form so you can provide us with your information, and we'll follow up in a couple weeks with that certification. But we want to again thank you all for joining us today, and really a big thank you to our speakers and individuals for supporting the planning of this event. We're so happy we could share this work and uplift MultiCare's hard efforts on supporting these patients. And so we are grateful for their time and expertise. And thank you, everybody, and we hope you have a wonderful day.